Good evening, everyone. I'm Tony Segreto, and the moderator for tonight's In the Know Town Hall. We welcome all of you. Tonight's focus, migraine. Our experts will shed light on the complexities of this neurological disorder that affects millions of people worldwide. Migraines are more than just a headache. It's a condition that impacts the physical, mental, and emotional health. 1 in 7 people globally make it one of the most common neurological disorders. The economic impact is essential and substantial, with billions of dollars being spent annually on healthcare costs and lost productivity. And did you know that migraines affect more women, about 3 times as many as men? It often coexists with other health conditions, such as depression, anxiety, and other chronic illnesses. Unfortunately, there remains a treatment gap, with many not receiving adequate care or diagnosis. Tonight, we'll explore the symptoms, the treatments, the underlying causes, and prevention options in not only adults, but children as well. Join me in welcoming Dr. Teshme Monteith. She's the Associate Professor of Clinical Neurology and Division of Headache Division. Dr. Paige Kalika, the Assistant Professor of Clinical Neurology in the Division of Pediatric Neurology. Dr. Lisa Smirnov, Assistant Professor for Clinical Neurology in the Headache Division. And Dr. Alexander Kokoris, Assistant Professor of Clinical Neurology and the Department of Neurology, and a quadruple cane. It is truly, as you can see, a world-class group of experts. Now, before we get started, let's go over how you can participate in tonight's conversation. Our panelists will answer questions that you submitted over the last few days. You will also have the opportunity, though, to submit your questions during this program. Please use the Q&A feature at the bottom of your screen. And remember, all the questions you submitted are anonymous. Now, let's get to our first question. Dr. Monteith, we welcome you. How is a migraine diagnosed?
Well, that's a great question to start with. What's really important is that migraine is diagnosed clinically. So it's diagnosed by the symptoms that patients are experiencing and by the lack of scary things. And these are things that would indicate a secondary headache disorder, something bad like a brain tumor, infection. Most of the time, chronic recurrent headache that's severe and disabling, it's going to be a migraine, just by the numbers and all that you mentioned. But in terms of the diagnosis, migraine is diagnosed by a moderate to severe, oftentimes unilateral throbbing headache with associated symptoms. These associated symptoms include disturbances of sensory stimulation, so light sensitivity, sound sensitivity, sometimes smell sensitivity, or even skin sensitivity, nausea, and vomiting. So that's the main way that migraine is diagnosed. And it's really important because we don't have a blood test to diagnose migraine. We don't have genetic markers or fancy ways, or even MRIs of the brain will not diagnose migraine. And so ruling out secondary causes of headache, confirming the disability associated with migraine is how we diagnose migraine.
You mean MRI will not diagnose it in any way?
No. We do an MRI of the brain just to make sure there's nothing scary or secondary that's the cause of migraine. And sometimes we order the MRI and we find things that have nothing to do with the migraine. And so it's really important not to, and I think we're going to talk about testing, but essentially it's a clinical diagnosis.
Thank you. Dr. Kokoris, what is a migraine and how is it different from other headaches?
So just like Dr. Monteith described, a migraine is more than just a headache, and it can be explained as a headache episode or a headache attack. It consists of specific features, like we mentioned about the throbbing head pain, sensitivity to sensory stimuli like light, noise, movement, and even smell or touch. And there tends to be nausea and sometimes vomiting. So these specific features make it different from other types of headaches. It's important to keep in mind that the attacks can vary from person to person and even within the same person. In general, with regard to migraine, someone can experience 4 different phases of an attack, and that also it differentiates it from other types of headaches. The attacks can last for hours up to days and can interfere with someone's ability to function.
Thank you, Doctor. Dr. Kessler, differences in treating the migraine between adults and children. What safe and effective approaches are there for treating children?
That's a really good question. In pediatric neurology, most of our treatment options have been tested out extensively in adults. And a lot of times we have to start using what we have available. And it does trickle down to us eventually. So usually we look to the adult world. We say, okay, what are treatments that have been effective and safe in adults? Is there any reason why we wouldn't want to use them in kids? And sometimes there's a reason. So a lot of the things that I'll suggest for my kids and adolescents is going to sound pretty similar to what their parents, who often have migraine, have already heard from their neurologists. A lot of times it's the same medications. A lot of times it's the same preventative strategies. There are not really a lot of treatments that I would use exclusively in kids that aren't also used in adults.
Dr. Smirnov, why is migraine more prevalent in women?
So I think that's a really important point because women are affected by migraine at almost a 3 times rate than men. And about 20% of women will experience migraine at some point in their life. So when we see this, we wonder what exactly is happening. And what we also notice is that when women are experiencing migraine, those are typically happening during the most productive years of their life. So somewhere between 25 and 45. And so what we start to think about is what roles do hormones and other factors play on migraines? More recent studies suggest that things like estrogen and things like prolactin can play a role. And so certainly we do see that with many of our patients.
It's interesting. Dr. Kessler, what triggers a migraine? Does stress trigger it? Does diet trigger it?
You named it. Stress is the major trigger of a migraine. And when we think of stress, we very often think of emotional stress. Oh, I'm so stressed out about school for kids or work for adults or family issues. But stress is a lot more than just our emotions, even though our emotions are very powerful. Stress is also physical stress. I tell my families all the time, eat well, sleep well, drink lots of water, because what are things that bring on headaches? Not sleeping well, skipping meals, getting dehydrated, changes in your environment. Things like this make it very easy to kind of tip over into having a migraine attack. It makes it easier because when our bodies are stressed, it doesn't take that much. So like Dr. Smirnov said before, it can be related to hormones. And for women who are menstruating, that may be a trigger. So there are lots of triggers, some of which can be unique to each person, but there are many common ones, and the most common ones are the ones that I mentioned already: dehydration, skipped meals, poor sleep, hormones, and just stress in general.
Dr. Kokoris, what should I do if a migraine is impacting my work?
The first thing I would recommend is to realize you're not alone. Like we mentioned, migraine headache disorder is one of the most common causes of health-related disability, and it tends to impact people in some of their most productive years of life. So if migraine is impacting your ability to function, whether that be in the workplace, at home, or even impacting your ability to do the things that you love to do, I recommend to start by speaking to your primary care doctor. Okay, they might recommend that you see a neurologist or a headache specialist. And there are many treatments available that can help reduce the burden that migraine can have on your ability to function, including ways to prevent the attacks from starting and ways to stop an attack once it has begun.
Dr. Kalika, are headaches in children dangerous? Does every child with headaches need an MRI or a CT scan?
That's a really important question, because that is 100% of the time what all the families are worried about when they come to me. Does my child have a brain tumor? There's something horribly wrong with my child? And the answer is usually no. Parents are often very surprised. Kids can get headaches just like big people do. And the only difference is that for some reason, as adults, we forget that we had headaches as kids. Many of the parents had headaches as kids, and it just didn't occur to them that it would happen to their kids. So not every child who has a headache needs an MRI or a CAT scan. So when do they need it? You come and you talk to the pediatrician, or you come in, you talk to a pediatric neurologist, and we ask our history. We ask a lot of questions. We do an exam. We look for red flags. Red flags are things that jump out at us and say, okay, maybe everything's fine, but this is something we pay attention to. We also look for what we call green flags, something that says, oh, this is pretty typical. This sounds really benign. This makes me think that this is probably just going to be a regular migraine, nothing unusual or scary about it. And then we discuss. I always tell the parents, we're going to talk through everything. And at the end, you'll understand why I'm making the recommendations I do. If I think we need a test, then we're definitely going to do a test. Well, at least I would recommend we do it. And if I don't think we need it, we'll talk about why.
Dr. Smirnoff, does exercise help? That's a key question because a lot of people have it.
Exercise is such an important part of migraine treatment. I think a lot of times we focus so much on what medications might help or what are the kind of traditional therapies that may be useful for me. But I think it's kind of easy sometimes to overlook some of the other really, really important lifestyle factors, and exercise is certainly one of them. There can be different exercise routines that certainly can help, but studies have shown that about 20 minutes of exercise, at least 3 times a week, can make as much of a difference sometimes as even some of our medications. So low impact exercises that do get your heart rate up, or exercises like yoga, can actually make a huge difference. Although I would add that they don't specifically replace all of the additional therapies and lifestyle interventions.
Yes, I can understand that. Dr. Kokoris, what are the risk factors? And are there anxiety? Does depression play a role? I know it does in women, but what about men?
Great question. So through research, we do have a better understanding of what factors can increase the likelihood of experiencing migraine. First is a family history. So we know that there's a risk for migraine that tends to run in families, and it is inherited genetically. Age can also influence someone's risk for migraine. It tends to start during adolescence and can worsen in people's 30s and 40s, like we mentioned. And then third are, we know that females are about 3 times more likely than males to experience migraine. Now, regarding anxiety and depression, we do know that these are 2 medical conditions that have been shown to be more likely to occur in patients with migraine. Other medical conditions that are more common in people with migraine include things like obesity, sleep disturbances, asthma, and irritable bowel syndrome. So it's likely that a lot of these medical conditions are inherited in similar ways and could be a reason why they're experienced together.
Interesting. Now, I'm going to throw this out to the whole panel. What are the treatment options? So who wants to go first? Dr. Monteith?
Well, I think it's important to, before diving into any one treatment option, to understand that there are non-pharmacological options, as what was mentioned, trigger management, sleep, hygiene, exercise, and then there's pharmaceutical management. So that's the broad categories. And then there's acute treatment management, so management of the acute migraine attack. And there are goals of care to evaluate the benefits of that acute treatment, whether it's working well or not. And then there's preventive treatment. And preventive treatment can, again, be non-pharmacological. It could be interventional, or it could be pharmacological. And there are a number of non-specific treatments that are not specifically designed for migraine based on the mechanisms. And there are more recent drugs that are designed with migraine in mind. For so long, for decades, we've had borrowed drugs that were used for other conditions that were borrowed and kind of by serendipity found to work in migraine. More recently, we have new drugs that really target the exact early. Migraine is a complicated disorder, but part of the migraine mechanism. So I'll start with that kind of broad, and then I'll let some of my colleagues talk about specific treatments and some things that they use.
Dr. Kalika.
So with kids, I always say that the most important thing is prevention. So I spend a lot of time talking with my families about ways to prevent the headache attack from even getting started. So like I said before, eat well, sleep well, drink lots of water, daily exercise, like Dr. Smirnoff said. And then I say, okay, what else can help? So some good things to start with are actually very easy. They're over the counter. There are actually some vitamins which can be helpful. There's vitamin B2, I would say B2, not B12, magnesium. These have evidence, and I always tell my families, you're always going to hear me talk about evidence-based medicine because no one really wants my opinion on things. You want me to tell you, what do we have evidence on? What has been studied? What seems to be the most effective thing to help? And in kids especially, we try to avoid medicine when possible. So this is a good way to start. There's evidence, and these things tend to be very gentle, very benign, with minor side effects, if any at all. So that's kind of where I start. I also talk a lot about non-pharmacological interventions like cognitive behavior therapy, because this is something that we also see can be very, very effective in kids and adolescents with migraine. This goes back to talking about stress. So stress triggers headaches, headaches trigger stress. We go round and round in a vicious cycle. We want to slow that roll, turn that vicious cycle into a virtuous cycle where we're feeling better. And I always warn them, none of these things work immediately. If you have someone who's been having, 2, 3, 4, 5 headache attacks week after week, month after month, it's going to take a little while to start digging ourselves out of that hole. So we have to be patient. It's, in a way, it's almost like going on a diet. You eat healthy one day, you exercise one day, and the next day, hey, nothing changed. It takes time. You have to, build your healthy habits, get into your good patterns of diet, exercise, good sleep, and eventually you start to see a response. And that's kind of our foundation. That's where we start. And after that, we say, okay, what else do we need? Do we need to start an everyday medicine? Because this is someone whose headaches are so severe, their attacks are so strong, they last for, not just 2 hours, but days. Or is this someone who, no, they have headaches less frequently, but can we get by with just, over-the-counter medication like ibuprofen, acetaminophen, Tylenol? And if so, good, we start with that. If not, we say, all right, we have prescription options which are safe and effective. There's a lot we can do there. And again, and I'll defer this to my adult colleagues, but there are these new amazing medications that have recently been approved, which are very, very effective. Unfortunately, they haven't quite trickled down into the pediatric world yet, but we're very excited and we're working on that.
Dr. Kokoris.
So when I talk about treatment options with my patients, I like to keep in mind choosing a treatment that's particular for them and having it be as individualized as possible. So sometimes we can make a decision for a treatment option based on the patient's comorbidities, possible side effects, their personal preferences, and what they have tried in the past. This helps me counsel the patient on their options and tell them and guide them into what might work best for them. So we do have many options, but we'd like to try to keep it personalized and as individualized as possible.
Dr. Smirnoff.
Sure, and I'd be happy to go into some of the kind of broad classes of these medications. So I think, as Dr. Monteith was saying, there are a number of medications that are actually borrowed from other classes. So there are anti-seizure medications, are antidepressant medications, and antihypertensive medications. And I think a lot of times when we're first presenting this, it may seem confusing, like, maybe the person doesn't have seizures, or they maybe don't have high blood pressure or depression or anxiety. However, these medications have actually been shown to be effective in migraine specifically. And like Dr. Kokoris said, sometimes these medications may be helpful for both migraine and then any other condition that the patient is experiencing. So we really do try to tailor the therapy to the patient. in more recent times, there are a few new therapies that are actually more specific for migraine. So there is a class of medications called anti-CGRP medications. They're either monoclonal antibodies or they're blockers. And so they work on a specific molecule that comes out of the brain during a migraine attack. And so this group of medications is really interesting because when other oral medications don't work, they give us new options and they give us new opportunities to treat the patient in a way that is more targeted to specifically migraine. Obviously, I think a lot of us also get questions about Botox for migraine, which is a really common treatment for our chronic migraine patients. So in those who really maybe don't respond to multiple oral medications, Botox done over the head, neck, and shoulders can actually be really useful for the purpose of treating chronic migraine. And just to kind of clarify, chronic migraine is when somebody is experiencing at least 15 headache days per month, with at least 8 of them being consistent with migraine. So we keep all of these things in mind, and I know that it gets a bit complicated, but I think that's why it's so important to look at each patient as an individual.
Thank you, Doctor. Dr. Monteith, this was just sent to us. Can you speak about postmenopausal migraine? Is this a lifelong condition?
So unlike some of my colleagues in much of neurology that, as people get older, they often have to give a negative news. So this could be about as people get older, the risk of stroke increases, the risk of dementia increases, and other neurodegenerative disorders. The nice thing about managing migraine is I get to tell people good news. I get to say that over time, your migraine should improve. And I do have patients that are older that say, well, how old do I have to be? Yeah. And I say, you're still young. Come on, you're sassy. Look at you. But generally speaking, if you look at the epidemiology, you'll see that over time, patients generally get better. Now, there is a transition period, this perimenopausal period. Patients could be more symptomatic. They could have hot flashes. They can have changes in sleep. And they could also have worsening migraine around that period of time. That's a transition time. But if they can get through that period of time, and we're here to help people get through that time, then the prognosis is actually quite excellent. And migraine is a brain state. So yes, migraine genetics, you're wired to have migraine. So if you go out and do things, you could trigger a migraine, absolutely. But the likelihood of having less migraine is really good. And people can sometimes get off some of these pharmaceutical medications that they've used for their entire life.
Thank you, Doctor. Dr. Smirnoff, are there alternative treatments for migraine? For example, what about magnesium as an alternative? Dr. Smirnoff?
Yes, so absolutely. I think as Dr. Kalika already mentioned, there are some nutraceuticals or vitamins that can actually be helpful for migraine. So the ones that, like she mentioned, have specific evidence base include magnesium. They include riboflavin, which is vitamin B2. There's also evidence for coenzyme Q10 and feverfew. So some of these, or all of them together in combination, can actually, for some people, make an impact of 20 or 30% in their migraines. Now, in addition to that, obviously, lifestyle changes are important. And then there are other additional treatments. So, for example, acupuncture is something that can be really useful to some of our migraine patients. Acupuncture, when done weekly over a course of 8 to 12 weeks, can also make an impact on migraine. There are also a number of new devices which can actually be used specifically to treat both migraine as a preventive, to prevent the migraines from occurring and to reduce them over time, or to act exactly at the onset of their migraine.
Thank you, Doctor. What is aura? Dr. Koukouris, is having it dangerous? That seems to be the question with aura. Is having it dangerous?
Right. This is a question I get a lot in my clinic. So what is aura? for about a third of people with migraine, aura can occur as a symptom along with their attacks. It can be considered a warning symptom in that it tends to happen before the headache phase, but it can also occur during, after, or even separate from a headache. An aura is a reversible symptom of the brain. It usually lasts 5 to 60 minutes, and it's most commonly a visual disturbance. So these can be flashes of light, zigzag lines, or blind spots in the vision. Other common aura symptoms include numbness or tingling in a particular part of the body, or trouble speaking. The aura can be, of course, very disorienting and bothersome, but it tends not to be harmful in and of itself in most cases. Now, it is important to note that people with migraine, especially women with migraine with aura, can be at a higher risk for stroke. This isn't necessarily cause for alarm because overall the stroke risk is fairly low, especially in patients who are young and otherwise healthy. Still, we do recommend that any patients with migraine with aura avoid smoking tobacco, avoid birth control pills with high levels of estrogen, and control the factors that they can control, like elevated blood pressure, blood sugar, weight, or cholesterol.
Thank you, Doctor. Dr. Kalika, this was just sent to us. There are lenses for glasses that are labeled for migraine sufferers. Do these work?
I'm guessing these are probably the blue light glasses. That's my best guess. This has been going around social media a lot lately. There's not a lot of evidence saying that they're helpful, but there's also not a lot of evidence saying that they're harmful. Usually what I'll tell people when they ask me is, well, if I don't think it's likely to hurt you, I'll say, well, try it. If it works for you, fantastic. I'm never going to tell you to do something that's working for you as long as it's not likely to hurt you in the end. A lot of times people say, well, it helped. I've had some of my families try this, and they'll say, well, it helped for a little while and then it stopped. I'm like, oh, okay. A lot of times what happens is we're seeing the placebo effect in action. So the placebo effect is this idea that, trying something, even if it may not have an actual method that it's helping, we're going to feel better. Our brain will do the magic and make us feel better. And we see this with a lot of things. We see it with medications. We see it with diets and exercise. A lot of things, even though we don't have evidence saying how it works or why it works, we feel better because our brain decided we're doing something, we're going to make ourselves feel better. And what I tell people is, I'm not knocking the placebo effect. If I can make you better with a sugar pill, I'll make you better with a sugar pill. The only catch is that as a doctor, it is not ethical of me to say this sugar pill is medicine. I will say this is not actual, but try it. And if you feel better on it, go ahead, try it.
I will say that some of the tinted lenses, the FL41s that are specific for certain light spectra is maybe useful to prevent light sensitivity for patients. So it's important that patients don't get those very dark glasses, because what happens is when you're wearing those very dark glasses and you're wearing them all the time, you may actually increase sensitivity. And migraine, we know, is a hypersensitive disorder, but the filtered light is very focused. And so FL41s would be the best ones to get for migraine.
Thank you, doctors. Dr. Kokoris, is there a correlation between triptans and higher AST, ALT levels, and kidney function?
So the triptan medications are a group of medicines. We use them to stop a migraine attack once one has started. They tend to be used at low doses and in limited quantities for each month. And we do have 7 of these triptan medications available in the United States for use. In general, they have not been shown to affect kidney or liver function and wouldn't be expected to increase blood levels of liver enzymes like ALT or AST.
Interesting. Thank you. Dr. Monteith, does continued nasal congestion cause headaches?
Why do I get this naughty question? And so, I mean, it's an important question because it's very common, actually. So what is the cause of this nasal congestion? The most common cause of nasal congestion is usually allergic rhinitis when it's recurrent, right? And so when you look at populations, it's actually one of the things that is most commonly associated with migraine, allergic rhinitis. It doesn't mean that the nasal congestion is causing migraine, but it's an associated what we call comorbidity. These disorders run together more than not. But it's important that when you have congestion, that you don't necessarily go to the default, I have a sinus headache. Sinus headache could be a mild pressure-like pain or discomfort that patients may experience. But if you're experiencing nasal congestion with any level of disability and it's recurrent and bothersome, especially if there are these associated symptoms that we spoke about, you should be very suspicious that this is just migraine. And so it's really important to know that because sinus headache is the #1 misdiagnosis of migraine. And so if you're going to the pharmacy and you're picking up over-the-counter nasal decongestants to try and treat your headache, you may help clear up some of the sinus symptoms, but you're not getting at that root cause of the problem. And so there's good reason to explain why nasal congestion can occur with migraine. It actually occurs in about 30% of people as part of the migraine mechanism and not a separate problem. So for that reason, I have a really good relationship with ENT because they send me, and we have really good ENT doctors here because they're able to identify migraine and they say, oh, we need to see him on T. And so I'm able to help them.
Very good. Dr. Smirnov, can migraines be a long COVID symptom?
So migraines certainly can develop after COVID. I think that's a really interesting phenomenon that we've seen. When we looked at patients who either had migraine or developed migraine after COVID, there were specific subgroups. So I think patients who already had migraine were likely to have worsening of their headaches after COVID infection. Patients who developed new migraines after COVID oftentimes had worse headaches for about 6 to 12 months. So I think that it's something that can certainly happen, and we've seen it happen after other infections as well. But can be a reason that things like some of our vaccinations can be actually protective potentially for our migraine patients.
Interesting. Dr. Monteith, can menopausal trigger a migraine?
In premenopause, so I think that's going back to that transition period, that period of time before a few years, could be even multiple years before menopause actually happens. And absolutely, that time tends to be also a time where you're tends to be most productive in life. And so that is a period of time that we start seeing patients come in sometimes for the first time.
Dr. Kalika, can weather be a cause of migraines?
Some people are very sensitive. It all goes back to stress and what stresses your body. And some people really notice that they're sensitive to change in weather, to barometric pressure. And they'll tell you, oh, yes, I know I'm going to get a headache because the pressure just dropped or there's a storm coming in. So some people have noticed that this is 100% one of their triggers. It's not for everybody. I actually see it a lot less than kids than adults seem to complain of it. So I'm not sure if it's just my patient population or something that maybe develops a little bit more as they get older.
Yeah. Dr. Monteith, what is best for ocular migraines?
Yeah, so it's, I think, first important to understand what is ocular migraine. And actually, ocular migraine is not a specific diagnosis used in what we call our classification system. So it's used in pretty much kind of lay audiences. But what I think people mean when they speak of ocular migraine is when you have visual disturbances, and those visual disturbances can be associated with headache. They can also can occur in isolation. So when they occur in isolation, some patients may experience visual loss, even flashes of light or complex visual patterns, and present to ophthalmologists. And then they're told that there's nothing wrong with their vision. They check the pressure, everything is fine. And they sometimes then get that diagnosis of migraine. So there's migraine aura without headache. There's what we call retinal migraine, where we think the pathophysiology is running along the retina, but that pathophysiology, I think, still needs to be sorted out. And then there's migraine with aura, which was mentioned. And really, the treatment is the same. So catching that aura, and there's a complex pathophysiology associated with that aura. We call that cortical spreading depression. Is probably more complicated than that. But the problem is that the medications that we have usually target the pain and not so much the visual disturbances. But what I would say is that if the visual disturbance is frequent and prolonged, then that might be an indication to get on preventive therapy. Because if you're on preventive therapy, and there's different preventive therapies that were mentioned, then you can lower your risk of having migraine with aura or visual disturbances associated with migraine mechanisms.
Thank you, Doctor. Dr. Kalika, can a neck cramp or similar cause a headache?
There's an interesting relationship between neck pain and headaches because there's a lot of overlap there. I think maybe 70% of people with migraine will complain of neck pain. A lot of people with neck pain complain of migraine. And we say, okay, well, what's the relationship? Is it causing it? And, well, yes, any kind of physical stressor can certainly bring on a headache. But something that's interesting and sometimes unrecognized is that neck pain can actually be a premonitory symptom. This can actually be one of the early warning signs that, headache is on its way. So before the headache part of the migraine starts, we have a lot of other things going on. A lot of times we can have an aura in that, percentage of the population that gets migraine with aura. But even if you don't have migraine with aura, we still have this migraine prodrome, these premonitory symptoms, which can start up to even a day or two before the headache part starts. And these can be pretty broad. It's mild symptoms that you might not even recognize. Maybe you have some congestion, maybe you're a little tired or extra thirsty, maybe you're urinating more often. And neck pain is one of these very common things that pops up. And a lot of times we don't actually make that connection. Hey, every time I get a headache, a day before, my neck starts to cramp up. So it can certainly be part of that. But there are also some people who say, no, my muscles get tight, and that triggers the headache. And okay, and that can also happen. So again, in pediatrics, my patients don't, luckily, tend to have quite as many neck problems as the older population do. But I actually have a few who have really tight muscles, and they found that helping that either with some medicine to help relax muscles or targeted physical therapy can be really helpful. But a lot of times I kind of side eye and say, I think this is really that premonitory symptom creeping up. Yes, you have headache, and yes, you have a neck cramp, but the relationship isn't exactly what you think it is.
Thank you, Doctor. Dr. Monteith, this was just sent to us. Can drinking alcohol, specifically red wine, cause trigger a migraine?
The person that asked that question already knows the answer to that question. So yes, absolutely. And it is one of the most common and reproducible causes of a migraine attack, and it doesn't happen to everyone. And then, we also have hangover headaches. So there are people that may not have an acute migraine attack. It may occur the following day, and that might be because of migraine biology. Now, I'm not trying to give anyone advice about alcohol, but I've been told that the clears tend to cause less migraine than the dark types of alcohol. Interestingly, there's been some studies showing that alcohol, for at least a subset of people, may actually reduce migraine. And so, but that might be a complicated web and not recommending it for that process. I do have some patients that they come to me and they're in horrible shape in terms of their migraine frequency. We get them in a good spot. They're having very little migraine, and they come back to me and they're like, I can drink again. And I'm like, wow, okay.
Yeah.
Happy to help.
You sure I can't get a prescription for that? Dr. Smirnoff, I have implants, not me, but I have implants, and I've read some medical articles on the subject of removing them, then they can contribute to migraines. Is it true?
So that's a really interesting question. Certainly, some of the recent literature shows that women with large breasts can actually experience more neck pain, more shoulder pain, and certainly more migraines. So certainly, I think in the case that the implants are contributing to additional weight, there is a possibility that they can be contributing. However, I think like Dr. Kalika said, it's really important to know that a lot of our migraine patients will have really tight neck and shoulders. Like, I think a lot of times when I examine patients, they'll say, I'm so tight here and it feels like a rock. And I hear that all the time. So I think it's really important to note that that's just part of migraine physiology. Those tight muscles are partially happening because of migraine. And so in some cases, things like breast augmentation can be helpful for certain patients, but I think that should be certainly discussed with a plastic surgeon. And I think other appropriate migraine treatment should be sought out first, so that it's less aggressive.
Can I have tight muscles and no migraine?
Yes, absolutely. So tight muscles can definitely happen without migraine. I think, when we're testing this with residents, when we've gone around, at least the proportion of them will have just really tight muscles. I think that there's a lot of association with stress and anxiety and other things. But, once in a while, you do find even that one lone neurology resident has very relaxed muscles. So it's certainly associated with migraine, but can happen with many other things.
Thank you, Doctor. Dr. Kokoris, how can I prevent stress-induced migraines, both those triggered by mental stress and by physical stress?
Right. So like we've discussed, migraine triggers can include changes in the body and changes outside of the body. And this can, of course, include stressful life events, even positive events. It also includes changes in your lifestyle, changes in routine, and other medical condition. So management of these changes and the stress that can happen with them can be very important in preventing migraine. Now, we can't control what stressful events happen to us for most of the time, but we can control the way we manage and approach the stress. And some very helpful techniques include mindfulness, meditation, and relaxation techniques. Of course, support from family and friends can be crucial, and continued healthy habits during stressful periods of time, including exercise and prioritizing things like proper sleep. In a great, majority of patients, I think speaking with a psychologist can also be helpful for managing stress and how it affects migraine.
Thank you, Doctor. Dr. Smirnoff, what can I do to prevent exercise-induced migraines? Intense cardio and weightlifting tend to trigger it for me.
So that's a really tough question because I think we get it a lot of the time. And a lot of times when we recommend exercise, a lot of the exercise we really focus on is low impact, and when with cardio, things like cycling, things that don't have as much of high impact as running, for example. Now, I think a lot of those things really depend on the migraine threshold. So the migraine threshold is how likely you are to have a migraine, because triggers are not all independent. They tend to be partial and additive. So typically when somebody's migraine threshold is really low, if I exercise, for example, maybe I'll get a migraine. Now, if I'm in a better place and my migraine threshold is much higher, it would have to be, poor sleep. It would have to be exercise of a certain kind, and maybe something else like red wine, like Dr. Monteith mentioned. So I think that the really key part there is kind of taking it easy on your body until you're ready. And so I think gradual exercise until it starts to be less of a trigger can be really helpful. And then also working with your doctor on migraine management so that that threshold goes up.
Interesting. Dr. Kalika, how about abdominal migraines? How can you prevent them?
That's a really good question, because abdominal migraines are very much underdiagnosed, because we all know kids, they just complain that their tummies hurt all the time. And sometimes we don't know, this is not always recognized, that this can actually be a form of migraine. Remember, migraine is not just a headache, it's more than headache. And younger kids can actually present with these migraines, which are not headaches at all. Kids present with frequent vomiting episodes. They are super, super dizzy. They have head tilt. And sometimes they just have these random episodes of belly pain. Usually it's not associated with too much vomiting, but they'll be kind of pale and they'll kind of cranky. Their tummies hurt. They don't want to play and do things. And a lot of times they'll actually have a headache too. They often won't complain about it because their stomachs are bothering them more, but that headache is often there in the background. And we treat it just like we do migraine with headache. It's the same kind of preventative treatment, and a lot of times the same kind of acute treatment, the treatment for, oh, you have this belly ache right now. A lot of times our migraine medications actually work for that. And that shows us that underneath the pathophysiology, how all these things are being triggered and handled in our bodies, in our brains, it's all the same kind of system. So it's actually the same treatment that we do for migraine attacks that are headaches.
Interesting. Doctor, thank you. I take Excedrin migraine for migraines, and it works for me. Is this correct, or should I try anything else, Dr. Koukouris?
Great question. A lot of our patients take Excedrin or have used it in the past. Excedrin is a combination pill, and it tends to contain caffeine. And although caffeine can be helpful in headache relief, it can also contribute to what we call rebound headache or medication overuse headache if it is used in abundance. So for this reason, headache specialists do not routinely recommend the use of Excedrin, but I want to keep in mind that there are so many other options for migraine stopping treatments that do not contain caffeine and can be effective for you, including things that are over the counter or prescription medications.
I want to keep you here, Dr. Koukouris. What foods can trigger migraines?
That's a great question, and something that we get very often in clinic as well. There are many different foods that can trigger migraine. Okay, it varies from patient to patient. So there's not really one list we can give all of our patients telling them to avoid each of these foods. What I usually recommend is that, of course, if a patient has identified a food that is triggering for them, definitely can avoid it, and hopefully that will reduce their migraine frequency. And, sometimes cutting out a food and seeing if that is helpful can be one of the most helpful things to see if it's a trigger for them.
Thank you, Doctor.
I'd
Dr.
love to add to that if that's possible.
Yeah.
I think
Yes, please.
I think the diet piece is so important. And I think a lot of our patients actually come in on some pretty intense elimination diets. And so I really love the way that Dr. Koukouris framed that in terms of focusing on specific triggers. But I think the other piece that's really important is that we generally don't recommend elimination diets, because a lot of times we have patients come in who've cut out, all of these delicious foods out of their life that are so important to them. And so I think it's important to still enjoy the foods that you have and specifically focus on the ones that are a consistent trigger. So keeping a headache diary for that purpose is so important, because then that might show you, for example, every time I eat chocolate, I have a migraine. But with things like bananas or avocados, it's really rarely. So it's probably just a correlation.
Any other doctor want to weigh in on this?
Yeah, so for the food triggers, I think, we're neurologists first. We're headache specialists, but we're neurologists first. So the concept of brain health is real and important. And so some of these foods are processed foods, junky foods, things that are not good for the system anyways. So I think in addition to caring about migraine, you have to care about your general health and your general well-being. And so I'm okay if someone is overly concerned about certain foods, if they're processed foods and probably not good for them anyways, artificial sweeteners, processed meats. There are other things that can be not well, so whole foods are, the best things that are living and alive are best for our brains and best for our hearts. We know that there's a brain heart connection dynamic, and there's a brain gut connection dynamic, and there's the microbiome. So all these things, while we don't have a lot of data, you don't need data to eat healthy. Of course, if there are things like certain fruits or vegetables that are triggering for you, yeah, maybe you can avoid those. But thinking in terms of well-being and general health is number one.
Dr. Kalika, would you like to weigh in on this?
Yes, because I was just
No,
thinking
you're
about
not.
it, because my perspective is a little bit different, just because in pediatrics, you guys may not have noticed, the kids tend to be picky. So I spend a lot of time telling them, please, 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 you have to eat something. I almost don't care what you eat, but please eat breakfast, please eat lunch, because it's a very classic story. I hear it multiple times a day. Yeah, no, I'm fine. It's just that the headaches usually starts around, I don't know, 1, 2 o'clock when I'm finishing up school. I'm like, you eat breakfast. So what do you eat for breakfast? Oh, I don't eat breakfast. Oh, well, what did you eat for? Oh, I don't eat lunch. I'm like, why do you think you're getting a headache? Your body is, you think of your body as a car. The car needs fuel. You run out of fuel, the car starts to complain. Well, actually, the car stops, but for a little while before the car stops, it complains. So while of course it would be wonderful if we can get all the kids on a whole food only diet, it'd be wonderful. But you know what? If the only thing I can get you to eat in the morning is granola bar, eat the granola bar. You want to eat this, eat something, please. And in kids, because they tend to be a lot more selective than adults, and unlike adults who can say, well, I may not enjoy this kale smoothie, but I know it's good for me. I'm sorry. It's really hard to get that kid to down the kale smoothie. Sometimes
I have some patients that are eating pizza every day, Diet Coke, like a liter of Diet Coke, like come on. And so there's probably some happy ground, right? And I hate
there's
that
no. There's
thing,
there's
but there's
absolutely happy
probably
ground.
there's probably some happy ground, right?
The ones who I'm talking about are the ones who just don't eat. I'm like, please eat something.
Yeah.
Eat something. Your body's running on empty.
Let me open this up to the whole panel now. Is there a gluten sensitivity that triggers migraines?
So I think certainly for somebody who has a known gluten sensitivity or gluten intolerance or celiac disease, that certainly can be a trigger for migraines. Otherwise, there really isn't a known association between gluten and migraines. So for everybody else, there's really not a clear association, so I wouldn't recommend avoiding it.
Anyone else want to weigh in?
Yeah, I think the whole gluten sensitivity train is wild. There's celiac disease, and there are probably some people that are sensitive to gluten, but generally speaking, it's super overdiagnosed. And like many things, it's very hard to isolate food triggers because they tend to, with the exception of nitrates, which is very reproducible, and alcohol that's very reproducible, very few triggers are actually reproducible. And we know chocolate, for example, while it can trigger some people's migraine, there's also a craving for chocolate. You take the chocolate, and we know that the craving, just a simple craving for chocolate, is a warning sign that a migraine is going to start. It's actually the earliest sign of migraine. And that goes for many of the triggers that we think are the actual trigger, but it's actually part of the biology and can be hard to predict.
You just mentioned one of my favorite studies. I always like to bring it up because I'm like, I know you always get a migraine after you eat chocolate, but chocolate doesn't always cause migraines. Migraines cause chocolate.
Well said.
And can we just say Dr. Kalika does not have any ties to the Hershey Company that I know of.
No, but I'm not going to say anything about lint.
What about canned foods? That triggered migraines? Canned foods? Dr. Monteith, Dr.
Not that I know of.
No.
Now, if you have a lot of salt or sodium in that can,
Yeah.
I think that's a different story.
Yeah. Well, let me throw this out.
Preservatives, there are other things that can sometimes be in that can.
Let me throw this out to the whole panel. What new innovations are you most excited about?
So I'm excited about novel treatments for migraine. We spoke already a little bit about personalized medicine. I'm excited about innovation that targets migraine specifically, and that includes medications that are safer to use. They have what we call less off-target side effects, and so they're not these borrowed drugs that are dirty and have multiple side effects because they're used for another condition. They're more specific to the migraine mechanism, so safer to use, better tolerated, because we know that that we prescribe these treatments for our patients. We think they're these wonderful plans, and sometimes our patients are not taking it. And if we follow these patients up in 6 months, they've stopped their medications. And we ask, why did you stop? If you even elicit that history, it's oftentimes the side effect profile or it wasn't effective. So I'm excited about migraine specific treatments that are actually targeting the migraine mechanism, and just the research acceleration in and of itself, the ability to find drugs or devices that are more sensitive to our patients.
Anyone else want to weigh in on this?
Not an innovation, but a trend that I'm personally excited about is just the increased interest in headache medicine among our medical students, our resident training doctors, and medical providers in general. So it's wonderful for me to see that there will be a greater number of providers for our patients, and this will increase the access to care and help patients get the care that they deserve.
Dr. Kalika?
My excitement mostly comes in knowing that there are already these, fascinating, wonderful, well-tolerated treatments in the adult world that are just starting to make it down into pediatrics. I'm very excited. Just before we started, I got a message from one of my 17-year-olds saying that she got one of these medications covered. It costs $500, but we're going to work on that. It's covered, and that's a place to start from. There's some of these new neuromodulation treatments are now approved in the pediatric age range. And I love this because everyone tells me, oh, I don't like medicine. I don't believe in medicine. I'm like, well, nobody likes medicine. Nobody wakes up and says, yeah, I want to go take some medicine. But we all wake up and say, hey, I don't want to have a headache today. And I really don't want my kid to have a headache today. So this is kind of like I can tell them, it's not a medicine. And everyone gets really happy about it. Same reason I like to recommend my nutraceuticals, the headache vitamins, because it's a vitamin. And then after I tell them, if a doctor says take this pill, and even if the pill is a vitamin, it's still kind of a medicine. I'm like, you understand that, right? But it works. And these are things that can be very helpful and very benign. So I'm so excited that we're starting to get access for it for kids and adolescents.
Thank you, Doctor. Dr. Sminoff, will end with you.
Yeah, and I would love to talk about the increase in advocacy for migraine, because I think that's something that's really exciting. Migraine has, for so many years, gone as an unrecognized and really undertreated disease. And I think that there's so much more focus on it now. There's a lot of different initiatives that bring advocacy for migraine. For example, we're doing this event. This is fantastic. And just to mention, we are doing a Miles for Migraine walk or run in December. It's a fantastic opportunity to connect with other migraineurs and to come out and support our headache fellowship as well, which supports new headache physicians for the community. So it's a wonderful opportunity if you are able to join us on December 9th.
Thank you. And thank you to our panelists, all of them, for exploring this condition. And thank you for joining us in tonight's In the Know Town Hall. I think you'll all agree that the hour flew by, wouldn't you say? Please remember that a full recording of this program will be posted online. Look for the link in coming days. And in a moment, you'll see a survey about the town hall on your screen. Please take a minute. I took it. It takes 30 seconds to submit your feedback. Help us understand your interest and improve your program. As always, wish you and your family good health. And remember, it's all about the you. Good night, everyone.